Hi everyone, in this video I'll be discussing the clinical features of MCL injury. So let's start. First, the function. So MCL is a ligament that is located on the medial aspect of the knee. Any structure that is located on the medial aspect is going to prevent forces that are directed from the lateral to medial aspect. So MCL is a ligament that is going to restrict forces that are directed from the lateral aspect of the knee. And these forces which are directed from lateral to medial direction are known as valgus forces. So the primary function of MCL ligament is to resist valgus forces. Second, MCL is a ligament that is located on the medial side. So it is going to, if this is tibia, it is going to restrict rotation towards the opposite side. So the second function of MCL is to resist rotation of the tibia in the lateral direction. So MCL has got two functions. Primary function is to restrict valgus forces at the knee. Valgus forces means those forces that are directed from the lateral to medial direction. And MCL being on the medial side is going to restrict these forces. Second, MCL is going to restrict lateral rotation of the tibia. Why lateral rotation? Because MCL is located on the medial side, so it is going to restrict the rotation on the opposite side. Now, once you've understood the function, let's move on to the mechanism of injury. Now, when does injury take place? When the load exceeds beyond the capacity of the ligament to withstand those forces. Now it can be of two types, contact and non-contact. Contact is when there is a direct blow on the outer aspect of the knee creating a valgus force. Non-contact is when there is external rotation of the tibia. Now these kind of injuries can occur in sports like football, basketball and so on. So most of the times patients they are not able to make out or they don't remember the exact position in which the injury took place, but still when you ask about the position in which they were injured, you will get a rough idea to understand, to make out which ligament or which structure is injured. Now let's move on to the clinical features. First is the location of pain. So why is it important to know the location of the pain? Because again that tells you that which structure is involved. So in case of MCL, the location of pain is most commonly the femoral attachment of this ligament. So there is tenderness at the medial epicondyle of the femur. Now commonly this ligament gets injured at this area, so you will see tenderness and pain localized to this region. But the ligament can get torn at other regions as well. So you need to palpate and find out the you can palpate and find out the location where it's injured. So how do you do that? You make the patient flex the knee at 20 to 30 degrees, and then you will palpate the entire ligament. Now this is not easy because for this you have to properly know the surface anatomy. You need to know the proximal and the distal attachment of the ligament. You need to know the joint line of the knee, and then you have to go from either any direction, proximal to distal, and then find out where the ligament is injured. Why will you do it in 20 to 30 degrees of knee flexion? Because this is the position in which MCL is taught, and there is minimal contribution from other valgus restraints of the knee. So you can make out if there is injury to the MCL. Next is the location of swelling. Now location of swelling will help you understand the extent of injury. If it is an isolated MCL injury, there will be localized soft tissue swelling around that ligament. But if you are able to see generalized knee effusion with hemarthrosis, then that indicates a possible ACL or PCL injury. Now why is that so? Because MCL is an extra-articular structure and ACL and PCL are intra-articular structures. So obviously if an intra-articular structure gets damaged, the swelling is going to be more and you see hemarthrosis. which is rarely seen in cases of MCL injury. So pain, swelling. Next is valgus stress test. Now majority of us fail to understand the significance of doing it in two positions, that is 0 degrees of knee flexion and 30 degrees of knee flexion. Why is it done in two positions and what is the significance of doing it in two positions? So MCL is a ligament which is maximally taut in 0 degrees of knee flexion. But in this position, there are other structures that help in restraining valgus stress at the knee. So if there is, if the valgus stress test is positive at 0 degrees of knee flexion, then it indicates that there is an associated injury to any one of the secondary valgus restraints as well. But in case of 30 degrees of knee flexion, maximal contribution to resist valgus stress is by MCL and the other structures are lax. So therefore, you will be able to make out if there is an associated injury with MCL. So if the valgus stress test is positive in 30 degrees of knee flexion, then it indicates an isolated MCL injury. But if the valgus stress test is positive at 0 degrees of knee flexion, then that indicates an associated injury to any one or more of secondary valgus restraints. Now what are the secondary valgus restraints? ACL, posteromedial capsule. So if these structures are injured, you will get the test positive at 0 degrees of knee flexion. Now what are we trying to find out with the valgus stress test? We are trying to find out the laxity of the ligament. So in which grades of tear will it be positive in second and third degree? So there are three grades, grade 1, 2 and 3. Grade 1 is when there is micro trauma to the ligament but there is no elongation. So you will feel the tenderness but there is no laxity. In second and third degree tear, you will feel the laxity. And how will you differentiate if it is a second degree and third degree tear? Obviously, the laxity that you will get in a third degree tear is going to be much more when compared to a second degree tear. And one more thing which is often missed is the quality of the end feel that you get in a second degree and third degree tear. In a second degree tear, the ligament is elongated but it is still intact. So the quality of end feel is firm. But in case of third degree tear, there is complete disruption. So you will get a soft end feel. So that is how you differentiate between a second degree and third degree tear. It is to be compared with the contralateral leg. The laxity that you get is to be compared with the contralateral leg, and rotation has to be avoided while doing this maneuver. Also, I have referred to three terms: swelling, edema and effusion. All of these are not the same. Swelling is a general term that refers to enlargement of a particular part. Edema is swelling that occurs outside the joint, and effusion is swelling that occurs inside the joint. And that is the reason when I said ACL or PCL injury, you will see effusion, that is swelling inside the joint. Why? Because ACL and PCL are intra-articular structures. And with an MCL injury, you will see swelling outside the joint, that is edema, and not effusion.